Well, thank you very much. It's my privilege to present this data on behalf of the Paragon investigators on 1-year echocardiographic results of bioprosthetic surgical valves in 4 major surgical trials. This is my declaration of interest. It's important to realize that all these trials were organized by Medtronic, and they also did all the data analysis on these trials. However, as Paragon investigators, we had full access to the data and to the analysis, so we're confident that this is all pretty interesting. So serial echo is an essential tool for monitoring valve performance, not only in terms of hemodynamics, but also in terms of structural valve deterioration and durability of bioprosthetic valves. However, they suffer from measurement variability. And previous analyses of normal valve function have been limited by the lack of modern valves, limited sample size, variability in data collection, and multiple no echocardiographic core laboratories. So our goal was to define a benchmark of contemporary surgical valves that were analyzed by one single core lab. We included 4 clinical trials and pooled all the surgical arms of these trials. The Paragon pivotal trial was a single-arm trial to study the efficacy and safety of the Avalus valve. And the other 3 trials, the Evolut low-risk, Surtavi, and core valve high-risk trials, were TAVR-SAVR trials comparing TAVR versus surgical AVR. The TAVR-SAVR studies were all, the data were analyzed by Mayo Clinic core lab. However, the Paragon data was initially analyzed by another core lab, and in order to compare all these echocardiographic results, we decided to reread all the Paragon data by Mayo Clinic. So therefore, we have one single core lab analyzing all the data, echo data of these patients. The trial was run in all over the world in 145 sites, including 14 countries, and almost 3,000 patients were randomly assigned in these studies. Obviously, these trials were very, very different, and I show you the study characteristics of these 4 trials. First of all, the enrollment period. The high-risk core valve study was obviously an older study. It was run between 2011 and 2012. Later on, the Surtavi followed, and an Evolut low-risk and Paragon were run about the same time. The number of surgical patients in these arms were somewhat different. Over 1,100 in the Paragon single-arm study, and then in Evolut R, Surtavi, and core valve, they were, as you can see in the table, 600, almost 800, and 350 patients. Also, the valve pathology was different. The SAVR-TAVR trials were all severe aortic stenosis, and the Paragon trial was both stenosis but also aortic regurgitation, and some of the patients had moderate aortic stenosis when they were operated for coronary artery disease and combined aortic valve replacement. So indeed, in the Paragon there was about 50% of concomitant procedures, and in the other trials it was very limited. The planned follow-up was 5 and 10 years in these studies. So therefore, the patient characteristics were different in these patients. The age was much higher in the high-risk study. It was around 83, and in Paragon was 70. The STS risk score was around 2 in the low-risk, and in the Paragon trial, up to 4.5 in Surtavi and 7.5 in the core valve study. Bicuspid valve was an exclusion criteria in the TAVR-SAVR studies, and about 30% of the Paragon patients had a bicuspid valve. And isolated aortic valve replacement was around 49% in Paragon and much higher in the other studies. So we pooled all these surgical arms of these trials and pooled them together to get almost 3,000 patients. We excluded 20 patients because they had a valve model implanted that was only used in 10 patients, which was insufficient to analyze. So we ended up with 2,938 patients. These were the valve models implanted, and it's logical that with the Paragon trial, including over 1,100 patients, that was the most prevalent model in that study. But still, there were over 700 Paramount valves implanted, and trifecta, mitral flow, mosaic, epic, Hancock, freestyle, intuity, and Percival. So 10 different models were implanted in these studies. The surgical valve implantation, all the Sever-Tever trials was up to the discretion of the surgeon. So in terms of the echo results, here you can see the mean aortic gradient of all these different valves pooled for all the valve sizes. I'll show you the valve size differentiation in a second. And these are the mean aortic gradients presented with a mean and standard deviation, a median and interquartile range. And for comparison purposes, I put here the mean aortic gradients, the mean of the mean aortic gradients of all these valves that varied from just below 10 for stentless and sutureless valves up to about 16 for stented porcine valves, and the stented pericardial valves are somewhere in between. So on the whole, these are very low gradients. Labeled by valve size, obviously these gradients are much lower for patients with larger valves, but still, if you look at the 19 and 21 millimeter valves, those gradients are not that high. They're around 15 for, up to 15 for label size 21 and below 20 for 19. They're somewhat higher for stented porcine valves, but if you look at the stentless and sutureless valves at these small valve sizes, those are very low gradients. Obviously, we also calculated effective orifice area for these valves, plotted here in this graph. They range from 1.5 to 2.0. And again, if we differentiate it by labeled valve size, it's obvious that the bigger valves have higher EOAs, and the smaller valves much lower EOAs. But again, the stentless and sutureless valves have significantly large EOAs. In order to get some comparison in terms of ppm, we plotted here the non-moderate and severe incidences of ppm in these patients. And you can see there's quite a range of severe ppm percentage. And of note is that the Avalus valve has a 3% ppm rate in this analysis, while in previous presentations on the 5-year and soon 7-year results, we reported a higher incidence of ppm, severe ppm in this cohort of patients. And that is completely due to the change of core lab. So we changed from one core lab to the other, and the ppm rate went down from almost 20 to now 3%. That was a big surprise to us. And when we analyzed that, it appeared to be the result of the measurement of the LVOT. So each lab has a different definition of how it measures LVOT, and as that's squared in the calculation of EOA and ppm, you can see that a small change in LVOT, way of measuring LVOT, makes a big difference in the percentage of severe ppm. This is, by the way, also consistent with the ACE registry, which captures the and uses not core lab, but site-reported echoes, which was a similar result as here. Finally, the transvalvular aortic regurgitation was very little in these patients and all these valves, and only one patient in the EPIC group had a severe valvular regurgitation. Now, obviously, there are limitations to these studies. There are huge differences in the patient populations among these different studies. The Perigon enrolled patients with bicuspid anatomy and regurgitant lesions. And the patients in Perigon and Evolute low risk were generally much healthier than in the other two trials, the core valve high risk and Surtavi. And the number of each valve model varied tremendously between this study, but still I think we can conclude that this is the largest cohort of contemporary bioprosthetic surgical aortic valves with 1-year echograms analyzed by a single core lab, with 10 different valve models and almost 3,000 patients. The overall hemodynamic performance at 1 year was generally good, with low average gradients over all valve sizes, and some models show excellent hemodynamics. This data set serves as a benchmark for other studies and a resource for monitoring bioprosthetic surgical aortic valve performance, both in terms of hemodynamics, but also if we look at the later follow-up times of structural valve deterioration and durability of bioprosthetic aortic valves. Thank you very much.